Hello everyone, I'm Juan Mario Martinez, a specialist in human reproduction. I'm based in Cartagena and part of the INSEAD Caribe group. Today, as we continue our symposium, I'll be discussing Mullerian anomalies. I believe this is a crucial topic as these conditions are often debated in daily practice. Which ones should be corrected, which shouldn't, and in some ways, they're alterations that aren't easy to diagnose. Even among our colleagues, there's often uncertainty about how to proceed when we encounter these Mullerian anomalies. To introduce the topic, Mullerian anomalies are malformations of female genital tracts, deviating from normal female anatomy, which can impact reproductive potential and fertility. Essentially, they're alterations in the formation, fusion, and absorption of the Mullerian ducts, which are the ducts that form during the urinary stage and help in the formation, especially of the uterus and fallopian tubes. So the fusion of Mullerian ducts and absorption failure can cause some abnormalities, like the well-known uterine septum, and others in more complex cases like uterine aplasia and certain uterine malformations. Regarding the epidemiology of these conditions, we have a global prevalence of 1 to 5%. This is what we currently have, in a way, as a possibility in the general population. There might be underreporting, which is likely because these conditions are difficult to diagnose. We may have underreporting regarding the incidence in the general population overall. They can cause, speaking of recurrent loss and Mullerian anomaly conditions, between 3 to 25% of miscarriages, and are also found in 8% of infertile women, and the most frequent cause to date remains the statistic of septate uterus or uterine septum. In Colombia, it's 2.6% in the general population and about 8.4% in infertile women. So what are they? As we just discussed, there are alterations in the Mullerian ducts development stages affecting formation, absorption, and fusion processes. What's their etiology? It's considered multifactorial, possibly polygenic, environmental radiation infections, past DES use, no longer used, which could have altered organ formation years ago, and toxins. Why are they so important? They can cause infertility and are a major factor in recurrent pregnancy loss for couples trying to conceive. How does it begin? What's the embryonic stage like? This typically occurs in the genital ridge and mesonephric ducts, as we can see here. These embryonic images show the early stages where Mullerian abnormalities begin to develop. In the undifferentiated stage, before sex determination, paramesonephric ducts form vaginal primordia, while mesonephric Wolffian ducts in males form the epididymis, vas deferens, and ejaculatory ducts. It's during this embryonic period that these alterations usually start. This image shows how different conditions arise based on when alterations occur in the first 6 weeks. If it occurs in the first 6 weeks, for instance, it's likely very early and could be uterine hypoplasia or agenesis. If it happens after week 7, it might lead to a bicornuate or didelphic uterus. And if it occurs after this, around weeks 9, 12, which are still quite early, it's mainly a resolution defect, resulting in conditions like a septate uterus. Conditions like didelphic uterus are mostly fusion defects, when the two parts fail to unite. Muller's ducts. In contrast, defects around week 12 are mostly reabsorption issues. This slide shows examples of reabsorption alterations. Here we see Muller's ducts fusing towards the urogenital sinus, with the inner wall gradually reabsorbing, forming the uterus. This internal reabsorption, if incomplete, typically leads to the formation of complete or partial septa. These are known as uterine septum defects. Various classifications of Mullerian anomalies have existed since 1848, with early systems emerging in the 19th century like Young's classification, which used simple odd diagrams to illustrate uterine variations. Such as a septate uterus, bicornuate uterus, and anomalies affecting the cervix and vagina. There were other types. Let's review these classifications. We'll soon see others in line with classifications from recent years, but this one I'm showing you has been the most significant. The 1988 American Society classification was used for many years. It described certain uterine anomalies, including the arcuate uterus, a normal variant. It had difficulty as it excluded vaginal and cervical alterations, making it complex to classify some intricate malformations within this system, right? Later, attempts were made to update with new classifications, though less widely used. This is the 1988 classification I mentioned, which shows simple graphs explaining all 7 possible conditions. In 2013, the European Society created a widely used classification with 6 anomalies. It includes vagina and cervix, making it easier to differentiate complex anomalies. Recently, ACBM updated in 2016, and in 2021, a new classification based on the 1988 model was made. I'll show it next. It's dynamic and can illustrate complex alterations. Currently, we're between the 2021 and 2013 classifications. This is the 2013 European classification, which is visually straightforward. One challenge has been the acronyms, which colleagues have found difficult to use in our field. U0 refers to a normal uterus, U1 to dimorphic uteri, U2 to various states, U3 to bicornuate uteri, including complete, incomplete, and partial bicornuate, and U4 to altered hemiuteri or those with rudimentary horns. This classification looks simple but can be tricky when reading reports without images or when viewing this diagram. This classification extends beyond U0 to U6, including cervical and vaginal abnormalities, with cervical abnormalities ranging from C0 to C4, though this isn't always the case. Plasia and dysplasia in the vagina should be normal to B4, which would be vaginal plasia. After this, discussing the uterine sector, which has been one of the most frequent and debated topics due to its impact on prognosis, effectiveness, and abortion risk. Later, ESRI, this society, and QMA also created an intermediate classification because these classifications have issues. ESRI is criticized for sometimes being overly optimistic, while ASRM tends to underestimate potential outcomes. QM developed an intermediate classification, which we see in this graph. The first is the European one, which requires an external indentation greater than 50%, an internal indentation greater than 50% with different lines from the waxy part interosseous, and in the final part of the cervix, which would be 50% of the endometrial thickness. The CUME tried to make a similar classification to the 2016 ASRM, using these measurements we see here of external indentation less than 10 mm and greater than 10 mm, and these from the 2016 ASRM, taking a slightly larger cervix of 15 mm with an angle of 90 degrees. This is the 2021 classification, divided into 9 groups as we see here, with the first 4 shown in the graph. It has the advantage of being dynamic, so while we can't do it here, if you follow the link on the page, you can move the images, especially for complex conditions, to see which one is closest to the patient's uterine abnormality. We also have the advantage that we can graph and say, in a way, its classification is much better than all the previous ones. Obviously, the 2013 version is still used in many places. The European one, I think, has adapted despite difficulties with U01, U02, etc. We're also trying to use this 2021 version in 1 or 2 groups. This graph relates to certus, which I think is good to always discuss in a very specific way. A partial certus is over a centimeter thick in the wall or certum itself, with an angle over 90 degrees. The normal one doesn't meet this criteria. For instance, an A4 would be less than a centimeter with an angle over 90 degrees, as shown in the graph on the results slide. These are the other types of certus. We're now at number 6, which would be the case of bicorporeal ones. Notice that the external indentation of the first graph is over a centimeter, and obviously it also has internal indentation. For the other one here, which could be another combination, there's also this variant of less than a centimeter. We need to correct it here. It's less than a centimeter, but greater than a full cert. This is like a mix of the alteration. Now, in this ACRM classification, which improves on previous ACRM versions, by including the vagina, we see it also shows vaginal alterations like these we're looking at, which are somewhat different septa in the vagina. They're also small blocks, and we need to watch out for that. These are the complex abnormalities from 2021, which it also classifies, allowing us to graph them, as I mentioned earlier, if one agrees with what we're seeing here. So, regarding diagnosis of Mullerian anomalies, there's always been a debate about the best diagnostic method for us to determine which one can help us identify the type of alteration we're dealing with. Clearly, we all have 2D ultrasound technology in our offices. Most ultrasound machines have this capability, and of course a transvaginal ultrasound, which only frontline doctors can perform, or a hysterosalpingography, at least to suspect the condition. In the case of a transvaginal ultrasound, we might see it when, for example, there are uterine septa, right? And some obvious alterations that can be seen if we have a good ultrasound machine. Hysterosalpingography has the drawback of not showing the outer uterine contour, but we can see internal cavity changes. Stereoscopy has the same drawback as stereosarcography. It shows the cavity, but not the uterus's external or lacerous structure. While stereoscopy and poroscopy have been used comparatively, as I'll show in upcoming slides, for different diagnostic methods, 3D ultrasound remains more robust for diagnosing Mullerian anomalies, with sensitivity and specificity similar to some MRI studies. These are the most reliable, but always keeping in mind that the person performing the study has proper training, right? To make an accurate diagnosis. For a transvaginal 3D ultrasound, they should know how to do it and use the classifications we're discussing. For MRIs done by radiologists, they should have experience in this specific study and examining Mullerian anomalies, right? Always in the diagnostic criteria when we're studying Mullerian anomalies, we must also be very careful to examine the kidneys, as 15 to 20% of cases have renal abnormalities like unilateral renal agenesis, especially with uniconnuate or didelphic uterus. This Dutch study wasn't very large. There are few studies on Mullerian anomalies that are prospective, randomized, controlled. Most are retrospective case control studies, and that's been one of the limitations of these conditions, and obviously the recommendations given with such studies. This was a multi-center, randomized, controlled, blinded study, but the sample size wasn't very large, we must admit, and it found no significant difference in primary and secondary outcomes, with the primary outcome being the live birth rate, right? This was in uterine, comparing uterine recession versus not recycling it in Pesser maneuvers. As you can see, the groups weren't large, 39 to 40 patients in the first group, and for the protocol itself, the intention to treat analysis, there were 36 and 33 patients. But we see that the live birth rate didn't change with or without resection, and clinical pregnancy, ongoing pregnancy, and even loss rates showed no significant differences. That's what this study shows us, though we must consider that the sample size wasn't very large. So what should be the diagnostic approach for different imaging techniques available for Mullerian anomalies? Comparing laparoscopy and hysteroscopy, which together are considered the gold standard for diagnosis. What did we find? We found that when comparing hysteroscopy and sonography in terms of sensitivity, specificity, positive and negative predictive values, they average about 86%. Obviously, some cases might be missed. It can help, but sensitivity and specificity aren't as high as we'd like. Regarding 2D ultrasound, compared to laparoscopy and hysteroscopy, in terms of sensitivity and specificity, we see that 2D ultrasound has a sensitivity of 67%, which isn't great, but a specificity of 98%, which is good. Positive predictive value is 94% and negative is 86%, averaging 86%. Clearly, it's a helpful study, but it's somewhat lacking in negative predictive value and sensitivity. Comparing laparoscopy and hysteroscopy to sonohysterography, we see that sonohysterography has good sensitivity, specificity, positive and negative predictive values, averaging 96.5%. For transvaginal 3D ultrasound, we see very good sensitivity and specificity. The positive and negative predictive value is good, with an accuracy of 97.6% at the end of the day. So I believe it remains one of the most useful tools among all the previous ones, right? Regarding MRI, at least in this review that looked at all these aspects, comparing it with hysteroscopy and laparoscopy, there were no studies evaluating MRI as a diagnostic tool as such, up to the date this was published. The studies include patients with a prior diagnosis of uterine anomaly under further evaluation, so I think there's no lack of data on MRI, but we do know it's a good tool and very comparable to 3D ultrasound, right? So in general, to summarize, we have that the most accurate are transvaginal 3D ultrasound, followed by sonohysterography, 2D ultrasound at 86%, hysteroscopy and hysterosonography very similar. It helps us especially with classifying complex anomalies. I won't go into detail, but I can discuss each type specifically, unlike the tubal type we've covered extensively. unicornuate or hemuterus can exist alone or with a rudimentary horn on the opposite side. The rudimentary horn is usually non-communicating, rarely communicating with functional endometrium. The rudimentary horn may have a cavity, potentially causing hematometra. In these cases, we must consider the possibility of resecting the functional rudimentary horn when it causes hematometra, as it often causes patient pain or can be associated with endometriosis. Treatment of the unicornuate uterus depends on its functionality, as discussed. If non-functional, it may not require intervention, but if functional, treatment might be necessary, depending on its connection to the main cavity. 44% of cases have urinary tract malformations, so it's crucial in this condition to consider renal ultrasound, as there's a high incidence of kidney abnormalities. As mentioned, treatment depends on whether it's functional or communicating and if it causes symptoms. If so, resection may be needed to reduce morbidity. To my people, a kiss. These are the grim results regarding unicornuate uterus and its treatment, but we see good preterm birth rates, yet high rates of miscarriage and ectopic pregnancy in the horn. So when we see they're functional and communicating, potentially causing erratic bleeding or even functioning, we should consider removing it, right? So it's done, as shown in the wedge image, resecting via laparotomy or laparoscopy, which is clearly better for the patient or depending on the condition. Consider hysteroscopic endometrial ablation, which is one alternative if possible. In the case of uterus didelphys, we know it's an alteration, mainly a fusion. When the fusion of the Mullerian ducts occurs, it can also present at the vaginal level, which is important to check. In this case, when we have a vaginal septum, it's an indication to remove the bicornuate uterus. The vaginal septum can hinder effectiveness, especially if the compliant side doesn't connect to the tube functionally, like where ablation occurred, right? Treatment for bicornuate uterus depends on symptoms or obstruction, sometimes presenting as hematometra or hematosalpinx. Always check for kidney issues. 20% have renal abnormalities. Options include surgery, but Strassman metroplasty is for specific cases rarely used. With bicornuate uterus, correction isn't always needed, especially with good uterine capacity. As mentioned, always consider resection carefully. Vaginal septa are simpler to operate on, making the procedure much easier for the surgeon. A bicornuate uterus, also called bicorporeal, is linked to recurrent miscarriages and preterm births. Surgery isn't recommended. Strassman's procedure is only advised for recurrent miscarriages, but it's controversial. There's a growing trend to avoid it in these two conditions. The implantation rate for a bicornuate uterus is 11%, while IVF clinical pregnancy rates are 44%. The disease treatment rate is 12%, and in some cases it's 14%. The disease treatment rate is 12%. 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 And the disease treatment rate is 12%. To determine if it's necessary to perform, if it's a state of bicornuate uterus with septum, a hysteroscopic metroplasty to correct it. Not all cases require this. Obviously, a bicornuate uterus without septum may not need metroplasty, right? I mean hysteroscopy, yes, or other types like astral metroplasty. For septate uterus, as discussed earlier, we must check if it's complete or partial. The partial type remains more common, right? Between these two, transvaginal ultrasound can help detect some variants and raise suspicion. It's linked to increased risk in August for some patients, with low chance of survival in premature births due to stress on the complete septum. Hysteroscopic resection definitely improves our results in assisted reproductive techniques. I think in our group, not all, but some of us need to correct uterine abnormalities, right? The treatment is hysteroscopic correction, correct? This area is vascular, hindering implantation and embryo growth, potentially causing recurrent miscarriages in many patients. So some aspects remain debatable, like using an IUD. Whether to use one or not is still controversial. Some use estrogen and progestogen regimens after reception, others don't. Some studies show no clear benefit. Some groups also suggest after reception, at follow-up after a month or two, to check if any touch-ups are needed, or to shorten the center if initial stereoscopy missed it. Cervical atresia is common with vaginal aplasia. Pregnancy chances are low, even after vaginal reconstruction. It's linked to endometriosis and cervical tubal factors. Initial treatment is for hematometra or retrograde menstruation. Pregnancies occur after IVF and embryo transfer. Transbiometrial transfer might be an option for embryo transfer. Laparoscopy is definitely uncommon in our day-to-day practice. Uterine aplasia is rare, affecting 1 in 5,000 women, causing primary infertility. Surrogacy is an obvious alternative when there's no uterus. For this patient, there's a good pregnancy rate and cumulative success rate. It's up to 50%. This option isn't accepted in some countries. In others, it's generally accepted but requires legal guidance from a specialized lawyer. Acceptance varies by country where it's being done. Uterine transplantation, growing recently, is still considered experimental. It's a treatment option where surrogacy isn't allowed. In cases of Mullerian anomalies for IVF patients, the approach depends on the specific condition. For unicornuate uterus cases, it's preferable to transfer embryos to the uterus with a thicker endometrium, which is more often found in the right uterus in these cases. Unicornuate uterus is linked to undescended testes. This is crucial for IVF, as egg retrieval may be challenging in this condition. We must consider this carefully and plan accordingly. This graph shows our approach for different Mullerian anomalies. Planning is crucial. Before IVF, we can examine most conditions using endoscopy, 3D or 2D heart scans, and MRI for a more precise diagnosis. We also consider endometriosis, as it's often associated with these conditions. A patient with a uterus didelphys might struggle to conceive naturally, but spontaneous pregnancy is possible. Endometriosis may also be present. Accurate diagnosis helps improve outcomes in assisted reproduction techniques. For unicornuate uterus, removing the rudimentary horn if functional will likely improve prognosis. For septate uterus, correcting the vaginal septum will facilitate embryo transfer in both cases. In all cases, ultrasounds are crucial to detect potential kidney abnormalities. It's closely linked to many of these kidney abnormalities. During assisted reproductive techniques for unicornuate uterus, as we just discussed, carefully monitor egg retrieval, especially from ovaries, sometimes in unusual locations. For didelphic and bicornuate uterus, try to perform the procedure in the uterus with better endometrium or features. In all cases, attempt single embryo transfers, as many are linked to preterm delivery, especially due to cervical incompetence in some cases. If we transfer 2 embryos, we know it increases the risk of premature birth. Post-RF for unicornuate uterus, be vigilant of ectopic pregnancy risk, miscarriages, and address if uncorrected. In all cases, try to perform early cervical length measurements due to the increased risk of preterm birth and cervical incompetence, okay? Also, do ultrasounds for all patients, as they tend to have abnormal presentations like breech, for example, which may require intervention. Remember, some kidney disorders are linked to a higher risk of preeclampsia, right? Well, that's what I had for you today. I hope you find it useful in identifying Mullerian anomalies in your daily practice and in guiding patients on what they need, whether assisted reproduction is necessary or not, and what should be corrected and when. Thank you very much. Have a great day.